or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the CEO and managing editor of VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Patient 360. And we've been very excited about this webinar. It's been a long time in coming, waiting for the final rule to get released. And so this one is called Finalized Policies in the CY 2026 Medicare Physician Fee Schedule Final Rule. It's a mouthful, but Amanda's going to explain all of it to us, and I'll introduce her in a moment. A few items of note before we get started. All attendees have joined today in listen-only mode, so we can't see you or hear you, but we are going to have time for some audience questions towards the end. Now, I will warn you, we have a lot of material to cover, and so we may go, it's very possible, we may go up to the last second and not have time to get to many audience questions, if at all, but don't worry, someone will reach out to answer your question. So if you have a question at any point throughout the presentation, go ahead and drop it in using your control module. There's a space for questions, and then someone will get back to you. But anyway, just wanted to give you a heads up about that. We're also going to have some polling questions so you can interact from home, and hope that you do. They are anonymous, so they're just for fun. But we're going to get to those in a moment. Finally, the session today is being recorded. And you are going to have an opportunity to rewatch it and download the slides, and you're going to want to do that because there's a lot of information on those slides. And so when we conclude, you're going to receive an email maybe about an hour or so afterwards, and there's going to be a link to the recording as well as to where you can download those slides. All right, well, without further ado, I'm going to turn it over to Miss Amanda Lord, and she is the Chief Policy Officer with Patient 360, and she is going to be our guide for today. So welcome, Amanda.
Thanks a lot, Garrett. Thanks for the warm welcome. And welcome to our attendees. Before we officially kick off here, just need to briefly highlight our disclaimer. Just remember to always check direct sources and verify with CMS. We are not CMS staff members, but we will make best efforts today to provide you with useful and accurate information. Okay, so let's walk through our agenda here. It's pretty packed. I am a fast talker, so I'll try to get us through it in an hour, but it's going to take a bit of time. Spoiler alert, first of all, for those of you who attended our proposed rule session, we do want to let you know that overall, most of the proposed policies were indeed finalized, right? So there were a few modifications and a couple of items that were not finalized, but most of the big ticket items that were proposed were indeed finalized. Another important item I wanted to quickly address about our topics in session today is intent. Similar to our session we hosted a few months back, for the proposed rule, our intent isn't to merely provide an abridged and regurgitated version and summary of the final rule. Most folks can glean the basics from the fact sheet and from attending the QPP calls where we do exactly that, provide an overview. Of course, we're going to have basic information about the key highlights of what was indeed finalized. But what we really hope to achieve today is for you to walk away from this call having some very specific and actionable items. So we want you to understand the why and how of some of these finalized policies may affect your organization and what you can do to prepare now for the 2026 changes. So with that, I know everybody has really busy schedules and we value your time. So we're going to delve right into this very packed agenda. First, Garrett is going to do a quick poll.
All right, so if you are playing along from home, you are going to see a poll come up onto your screen. And the question is this: have you been able to read the 2026 Physician Fee Schedule Final Rule in all of its 1,000+ pages? And you can be honest here. This is anonymous. I've read most or all entire document, or I've read some of the key highlights important to my organization, or I have read little or none of it. And you know what? Don't be ashamed about that. That's okay. I am one of those that have read very little or none of it. So we're going to get the synopsis today. So I think most of the responses have come in. We'll give it maybe another 5 long seconds, and then we will look at the results and we'll share those results with you. And then Amanda, when this pops up on the screen, go ahead and, if you would, we may have some people calling in from the phone, cannot see the visuals. So if you could read out the percentages, that would be awesome. So, all right, I'm going to go ahead and share the results. Here we go.
Thanks, Garrett. Can you read them?
Oh, yeah, sure. So we've got 52% of you said I have read little or none of it. And 52% of you are also very honest individuals, so appreciate that. Then we've got 44% of you, which makes sense. It says I've read some or the key highlights important to my organization. Then we have some nerds among us. who have read the whole thing, and including Amanda herself. So I've read most of her,
Yeah.
and this is 3% of you. So, all right, we've got a
Oh,
good,
wow.
good cross section today.
Okay, well, I'm looking forward to nerding out with some of you. And then for those of you that haven't read anything, I want you to make use of this, right? We're going to send you a copy. You'll have the recording, so you don't have to go back and refer every single slide. And that's, as a matter of fact, I'm going to go over the final rule page number references here with you all. Natea, if we can go to that slide. This is how to understand our page number references on most of the slides that you're going to see. So these page numbers are directly from the published version of the final rule. So there's a bunch of different versions. Just this one is the published version. So these are the page numbers on the slides that we're referencing. So we're going to cite both the PDF page number for you and then the federal regulatory page number. So if you don't want to read the whole final rule, but you want to go back and dig into something and sink your teeth into it, we have page numbers on all the slides so that you can go right there into the final rule. Next slide. Okay, here we go. So Medicare Shared Savings Program participation. So final policy for the one-sided risk model. This rule limits an ACO's participation in a one-sided risk model of the basic track to a maximum of 5 performance years within its first agreement period. This is a reduction from the previous limit, which was a maximum of 7 performance years. The effective date. So this new 5-year limit applies to ACOs beginning agreement periods on or after January 1st of 2027. It was generally supported by stakeholders in the feedback and the comments, and health policy organizations, as most agree that it's to encourage and accelerate the transition to two-sided risk model. So flexible finalized timeline. Previously, an ACO could generally only add a new ACO participant like one created from a CHOW during the annual application cycle, effective the following performance year. This created a significant data and reporting gap. So the new policy finalized in the rule creates a mid-year notification pathway for a specific common sense scenario. So the finalized policy is basically an ACO can now submit a CHOW notification outside of the annual cycle, so mid-year, if the CHOW results in a newly formed legal entity, a new tax identification number, that has no prior Medicare billing history. And so what does this solve? This flexibility is for situations where a practice is acquired and rolled into a new TIN. Under the old rule, that new TIN couldn't join the ACO until the next year, which was pretty annoying. So now the ACO can notify CMS mid-year. CMS will approve its addition to the ACO participant list for the current performance year. This ensures the new TIN and its providers are properly included in the ACO's quality reporting, financial reconciliation, and the beneficiary assignment from the start. Next slide, please. Okay, so here we've got a bit more about the finalized eligible policy for smaller ACOs. So if you're a smaller ACO listening in right now, this slide is relevant to you. For agreement periods beginning on or after January 1st of 2027, CMS finalized its proposal to allow new ACOs to participate in the MSSP, even if they don't meet the 5,000 beneficiary minimum in benchmark year 1, benchmark year 2, provided that they meet the minimum benchmark in the 3rd year. CMS also finalized safeguards for this flexibility. So ACOs using this on-ramp will be limited to the basic track. They will be subject to a cap on their shared savings and losses. And this proposal, it was supported by commenters. Its primary benefit is that it creates a more flexible and stable on-ramp for organizations that want to join the MSSP, but don't have a large enough attributed population at the very start. This flexibility is going to be helpful for you if you're a smaller organization, if you have rural providers, and for ACOs that are serving in underserved communities. So these groups often struggle to meet the 5,000 beneficiary threshold immediately, and this policy allows them to enter the program and grow their assigned population over the first 2 years, rather than being excluded from participation entirely. Next slide. Okay, so beneficiaries eligible for Medicare CQMs. Okay, so CMS finalized the definition, and how does this impact the actual rosters that you load into Patient 360? So if you're a P360 client, you know exactly what I'm talking about when I say the rosters. How does this influence them? So the ACO is not going to have an obligation to report on beneficiaries without a PCS encounter field, okay, because those beneficiaries haven't had a primary care service. Who does this impact? Like I said, only those ACOs reporting via MCQM collection type. So if you're tuning in right now and you're doing ECQMs, this really doesn't apply to you. If you're doing MCQMs, this is what you want to focus on. The text in the final rule explains that this is how the process is going to work for 2025. So right now, it's happening right now. The transition phase, 2025, the Q2 and Q3 rosters, most of you have already uploaded the Q2 and the Q3s will be out any day now. The quarterly lists are still going to be based on the old definition, but CMS has added an additional variable, the PCS encounter field, to flag the beneficiaries who meet the new definition, meaning they had a primary care service. During this time, your reporting obligation is limited to those with the flagger number 1. So see in the slide there, column H, the PCS encounter. If you've been looking at your rosters and you've seen that, because they kind of snuck it in there in Q2, and everyone was like, what is this flag for? If there's a 1, you want to focus on those patients the most at this point. And then what's going to happen is that fully implemented Q4 roster and beyond, starting with the Q4 for performance year 25, the roster itself is going to be based on the new and finalized definition. So this means that only beneficiaries that have at least 1 primary care service encounter during the list period will be included in the Medicare CQM quarterly list. At that point, the PCS encounter field is going to be removed because everyone on the list will by definition be eligible for reporting, because only PCS patients are going to actually be on the final roster. So that column H will drop off. You won't need to see the number 1 because everybody that's going to be on the final roster is going to be a PCS patient. Any questions about that when you're thinking about it as it applies to the rosters that you're loading to P360, just let us know during our implementation calls and we can help you. Next slide, please. These are just routine updates. So they finalize routine changes to the list of CPT codes and HCPCS codes that are used to identify and define primary care services for the purpose of assigning Medicare fee-for-service beneficiaries to an ACO. So this is now going to be done on an annual basis through the regular physician fee schedule rulemaking process. It allows the list to remain current as new care management and primary care codes are introduced. As for the removal of GO136, CMS didn't finalize the removal. Instead, they revised the code descriptor to the following text: GO136, administration of a standardized evidence-based assessment of physical activity and nutrition. Since HCPCS code GO136 is not being deleted and it remains a payable service under the PFS, CMS is not removing the code from the definition of primary care services used for the purposes of assignment. Next slide, please. These are just some additional finalized policies. So the removal of the health equity adjustment, the finalized removal of the health equity adjustment will not retroactively apply to 2025 as proposed. Instead, it's going to begin for 2026. That's going to give ACOs more time to prepare for the loss of the adjustment. And why are they removing it? Similar to what we talked about in the proposed rule, there's other incentives already available for ECQM and CQM all-payer submissions, such as the complex organizational adjustments, and those come with ECQM bonus points. So they're removing duplicative incentives, essentially. EUC details. So finalized expansion of the application of the quality and finance EUC policies to an ACO that's impacted by a cyber attack. This was finalized. CMS noted in the rule that commenters were supportive of this change, citing that there's obviously significant disruption and financial hardship that cyber attacks cause for providers. And so how is the verification determined? This has always been the same. It's in this final rule, it's in the proposed rule, but it basically confirms that the existing framework is being maintained, that the new cyber attack policy is going to be integrated into the existing framework, right? And so it's essentially you're determined to be affected by an EUC if either of the following is true. If your ACO's legal entity is located in an area identified by CMS as being affected by the EUC, or if 20% or more of your assigned beneficiaries reside in an area identified by CMS as being affected by the EUC. So again, this was finalized for cyber attacks, the EUC. Next slide, please. Okay, so we did advocate to expand this EUC for specialty TIN challenges. So we formally advocated for the structural challenges many of you face with specialty TIN. Specifically, we submitted the following comment regarding the EUC framework. So I want everyone to hear that we really did try to advocate for this. The EUC framework fails to address structurally ineligible specialty TINs. As detailed in our previous comments on ACO composition, many ACOs include specialty TINs, dermatology, orthopedics, ophthalmology, radiology, that are structurally unable to report on the required APP measures. These measures are not applicable to their scope of practice, and their certified EHRs are not designed to capture the necessary data, or they might not be on CERT. Currently, these TINs have no recourse as the EUC policy does not recognize this as a valid circumstance for relief. So while CMS did acknowledge the difficulty regarding specialty TINs, they ultimately deemed our proposal to expand the EUC policy out of scope for this specific rule, and instead they offered an exemption. Instead of offering an exemption, they directed ACOs facing unresolvable EHR issues to the formal complaint process, which is on page 545 of the final rule, and I popped a link in there for you. For ACOs with significant EHR vendor concerns when issues of potential non-compliance, so this is right from the final rule, It's a quote. For ACOs with significant EHR vendor concerns when issues of potential non-compliance with certification requirements are unresolvable, we note that the Assistant Secretary for Technology Policy Office of the National Coordinator for Health Information Technology, has provided a complaint process for certified products to the public available at the link that we popped in the slide for you. So since CMS has confirmed that they're not going to offer data completeness exceptions or EU hardship relief for these specific scenarios that I just mentioned, proactive TIN participant planning is really now more critical than ever. We recommend using your end of summer roster planning sessions to evaluate TIN composition carefully by ensuring early that every member TIN is educated on the APP requirements and capable of producing data. You can avoid surprises later in the year. So with that in mind, let's actually look at what are those required measures for the program. So next slide, this is the 2026 performance period. Measure 113, as we know, that has officially been finalized. We know from our collective experience with Measure 112 this year that obtaining this data can be complex, especially regarding EHR connectivity and non-aligned specialties. Since we know that CMS, again, doesn't intend to expand the EUC exemptions for these operational challenges, we have a real opportunity right now to get ahead of the curve. We recommend engaging with your TINs and EHR vendors early to strategize. If you apply the lessons learned from this year, we can ensure everyone is set up for a smooth and successful 2026. Next slide, please. Okay, so this is just a quick update on the breast cancer screening measure for 2026. If you're an MSSP ACO reporting ECQM collection type, they did finalize changes to the breast cancer screening measure 112 for 2026. The ECQM for 2026 is going to align with the CQM, which is what commenters pointed out. We all knew about this, that they were misaligned, the specs between the ECQMs and the CQMs. So they did finalize to align them. It's important to note that the ECQM collection type is actually going to have 2 strata now, which will likely mean EHR changes to programming are going to be required. So we suggest that those of you who are planning on submitting 112 as the ECQM collection type begin working with your EHRs now on the specification changes to ensure that your workflow and documentation within the EHR align with the updated strata. And you can see those here on this slide, plus details are in the appendix in the final rule, and we've cited that down the bottom for you. Okay, next slide, please. All right, APP plus measures on the roadmap just for the future. It's important to note that measures that are on the roadmap for addition to the APP plus set in 2027 and 2028, those are substance use disorder, treatment and adult immunization, substance use disorder, treatment and adult immunization status. Oof, that was a long one. Removal of measures. The 2026 final rule finalized the removal of quality measure 487. So that was proposed. We knew that was coming, and it's screening for social drivers of health from the APP plus quality measure set. So this move was part of a broader, largely supported strategic shift by CMS to streamline the entire MIPS measure inventory. While some commenters, they might have wanted to keep the SDOH measure, I did read a bunch of those. The general move to reduce the burden of the check the box process measures and focus on outcomes has been a long-standing request from stakeholders, and it's been an initiative for CMS for a long time. So we weren't really surprised about this removal. The final caps for MIPS survey policy, that's a good one. They did finalize it. It's the web first model. So vendors must first attempt to reach the beneficiary via web email. If that fails, they move to mail. And if that fails, they move to phone. And this is kind of a win-win because it modernizes the survey and it's more convenient for many beneficiaries and results in better data for everyone. I don't think I saw any comments that were against that. Everyone said, yeah, this is good. Okay, next slide. Oh, PI. I think everybody knows about PI, but I wanted a placeholder here just to remind folks. So it was previously finalized for 2025 that the promoting interoperability category is indeed required for MSSP ACOs. Why did CMS do this? So they're trying to better align SSP cert requirements with the MIPS PI requirements in order to report on the promoting interoperability category. So a lot of you probably know this, but if you don't, great, you can come back here and take a look at it. You have to use certified 2015 electronic health record technology, that's otherwise known as CERT, report on the objectives and measures required under PI, including attestation statements as required by CMS for a continuous 180-day reporting period. This changed last year. It used to be 90 days. It's now been 180 days for 2025, and it will continue to be 180 days. You can be excluded from reporting the MIPS PI category if you meet any of the applicable exclusions on this slide. So take a closer look at that later, just to make sure, because you don't want to be stuck at the end of the year. If you're not sure about your promoting interoperability eligibility, you can use the tools and the links on this slide to check the status of your ACO and your member TINs. PI can indeed be reported by Patient 360. So if you do need to report PI, just let us know and we can assist. Again, July started the 180-day time frame, so we can start receiving data. You can send it from January to July. You can cross PI off your list right now, or you can send whatever you have for the full year. It's fine. It can be more than 180 days. One less category to worry about if you get started now, if you need to do it. Next slide, please. Okay, so the future. What's on the horizon overall for the APP program? So FHIR is fully on the roadmap. We did submit robust RFI responses, and here's some of the concepts that we touched upon, just so everyone knows that this was one that we focused on quite a bit. There were, I don't even know how many RFIs, a lot, like 5 or 10 of them. But the FHIR one was one of the biggest ones that we commented on. So we talked a bit about implementation timelines. We recommended more than the 24 months. We want to allow time for vendor development, provider adoption, registry integration. We talked a lot about technical and operational barriers just because we've already started with some of our clients looking into FHIR. So we know that there's we provided extensive details on bulk FHIR scalability failures like timeouts, inability to handle volume, the critical need for API filtering, TIN and NPI level queries, the lack of transparent data mapping from EHRs. So that was a big thing that we focused on in our RFI. And then the need for CMS provided tools and resources. So P360 gave CMS a roadmap of necessary tools, including a developer sandbox, an enhanced Cypress testing tool, a FHIR to QRDA conversion tool to serve as a transitional bridge. So what does the shift basically mean to FHIR? What is that going to mean for ACOs? Basically, as they said in the proposed rule, and they're continuing to say it in the finalized rule, it's not like it's going to happen tomorrow. It's going to be a phased approach, with CMS initially removing collection types that don't support the shift to DQMs. They're planning to streamline the quality measure collection types to focus on eCQMs and Medicare CQMs. They're going to retire the MIPS CQM collection type, probably beginning with 2027, and they're possibly looking to sunset Medicare CQMs by 2030. So it's coming. What can you do now to prepare? So you can start reporting eCQM collection type as much as possible. This means TIN education and urging your member TINs, as many of you know through experience, to ensure their EHR products are 100% 2015 cert. Aside from this putting your ACO ahead of the game for the future, reporting eCQM collection type now at present does have other benefits. So your performance scores are typically going to be better because the benchmarks don't top out, because the data can't actually be manually manipulated. And it also organically includes the entire eligible population, so you don't have to worry about tracking data completeness. So that's super helpful. The data is always going to be 100% complete when it's sent using an eCQM collection type. There's bonus points awarded to measures that are submitted under the eCQM collection type. So again, lots of benefits to submitting eCQM collection type now rather than waiting. Bottom line is that FHIR is coming. eCQMs are the pathway to get there, and starting now with eCQM is really, really important. Next slide, please. Okay, so we're wrapping up our MSSP section. What can we do to be prepared for 2026 and also successful data here in 2025? Because we're at the end now and we're getting swaths of data and we're validating and doing all of the things, right, to be successful here in 2025. So understand what's been finalized and apply those best practices now by sending P360 data early and often and validating your data in a consistent manner. That's actually one mantra that we are aligned with CMS on. Send your data early and often. I feel like we say that a lot. So that's really, really important. It can't be underestimated how important that is. For 2026, if you haven't yet contracted with Patient 360, you should begin the process now so you can hit the ground running in the first quarter of 2026. You don't want to wait until summer, late summer, fall to just start sending your data. You should get started in Q1. For 2025 current participants, CMS should be releasing your Q3 roster, the MCQM roster, anytime now. If they haven't already, it's right around now. If you know your ACO can't report all of the eCQM collection type, you want to upload your MCQM roster now, if you haven't already, to P360, which will ease some of your burden. And you want to begin using the gap reports now to complete your MCQM templates. Those gap reports are reports that we produce for you to understand what data is missing. If you're still uncertain about the PI category, you want to check your PI eligibility as soon as possible to determine if you have member TINs who are required, so that this doesn't slip through the cracks. You're not scurrying around during the holidays trying to get promoting interoperability or even figure out what it is. So really important to get that under your belt now. Okay, so that's everything for MSSP in terms of future. We're going to revisit some action items later. Now we're going to shift gears a bit so we can go through MIPS and MVPs, and then after we're going to go over to the ASM model. So next slide, please. And just a quick sip of water. And Garrett, a quick sound check-in. Everything loud and clear?
Everything sounds really good. One quick question that came in here. Does this apply to the new enhanced MSSPs?
So we're talking about both risk models. So the final rule, there's data, information, everything in there about policies for one-sided risk model and two-sided risk models.
Gotcha. Thank you.
Okay, so MIPS finalized policies. Before we discuss the 2026 MIPS policy, just a quick heads up to everyone, the 2024 final scores, those have been out for a while, at least a couple of months. So it's important to log into QPP and view those scores. Look at your past performance, because that's going to help inform you on what you need to do today in the here and now. Payment adjustments for your 2024 score will be applied to Medicare Part B claims starting on January 1st of 2026. Two most important aspects of MIPS, performance threshold and data completeness, are holding steady at 75. We knew that was going to be finalized. Everyone's glad about that. I don't think there were any commenters that were like, no, please raise the threshold. Nobody wants to do that. Next slide. Okay, quick look. This is just a placeholder on the new MIPS quality measures. There's 5 finalized for quality measures for 2026, and you can see that they're all leaning heavily towards outcomes-based reporting. This has been coming for a long time. We know the shift from process-based to outcomes, and it's going to continue to be that way as we move through a rulemaking process over the next few years. Next slide is retired quality measures. So finalized removal focuses on process measures, like I just said, measures reaching extremely topped-out status or the end of topped-out measure life cycle, measures no longer align with clinical guidelines, and measures the steward would no longer maintain. Okay, next slide. This is quality category finalization. So it's important to be aware of measures finalized with substantive changes, because you can see those changes in the appendices of the final rule. So this is super helpful. It makes advanced planning a little bit easier, especially for the CQM measures, where the updated specifications for those, as we all know, aren't released until the end of December. Usually it's just right around the holidays. Great timing. So this allows you to actually be able to see the substantive changes. I mean, it's painful to go through and go to the appendices, but we've got at least the pages of where to find them, so you can see which measures have had changes. It's also crucial to understand the policy on topped out measures and what was finalized. So normally when a measure is topped out for 2 consecutive years, its scoring is capped at a maximum of 7 points. After 3 years, CMS might even remove it entirely, which is a major concern for some specialists who really have a limited number of measures to report. However, CMS did finalize an important exception to this rule. So to avoid penalizing clinicians in specialties with few measure options, they did finalize a list of 19 topped out measures for 2026 that are going to be scored using an alternative benchmark. And it's good news, because it means that those 19 measures aren't subject to the 7-point cap. So you could still earn up to potentially 10 points if you're doing well on them, and avoid being disadvantaged just because your specialty has limited reporting options. So that's a good thing. If you want to know those 19 measures that can still earn up to the 10 points, they're located on page 641 of the final rule, and all the details, again, right here on this slide on the bottom right, page 641, so you can go and check. Cost category finalizations. Okay, so the 2-year informational only feedback period was finalized as proposed. It's effective for new cost measures starting in the 2026 performance year. The reason CMS finalized this policy is because it provides a longer runway for clinicians to gain familiarity with new measures before they are used for scoring. CMS did not finalize any new cost measures or remove any existing ones for 2026. So there's a total of 35, with 33 being episode-based and 2 being population-based. The only changes to existing measures were the finalized technical modifications to the total per capita cost, TPCC, measures attribution logic to prevent unfair cost assignment to certain specialty practices. Related to the new informational only feedback period that was finalized, P360 and other commenters, we did suggest, we tried, making the new policy apply retroactively to the low back pain cost measure that was included for the 2024 performance period. And CMS actually did acknowledge the comment and suggestion, but they denied the request, unfortunately, since retroactive application wasn't in the proposal and it would have caused operational challenges. They explained that doing so presents significant operational challenges and could disrupt ongoing implementation efforts for the measure, which is already live. But we wanted you to know that we did try for that, and we formally put that in our comments. Okay, next slide. Improvement activity finalizations, pretty self-explanatory slide. The 2026 final rule demonstrates that CMS is evolving improvement activities category to better align with its new strategic focus. So we can see that this is most evident in 2 of the key finalized policies. There's a new subcategory. They finalized the removal of the achieving health equity subcategory and replaced it with the new advancing health and wellness subcategory. So this does signal a clear shift toward prioritizing prevention and overall well-being. And then new clinical activities, the new focus is also reflected in the new activities added for 2026, such as improving detection of cognitive impairment in primary care and integrating oral health in primary care. Both of those emphasize proactive and preventive health management over simple process. Again, there's that theme of moving from process to outcomes. Okay, next slide, promoting interoperability finalizations. Okay, for the PI category. So the previously finalized suppression of the electronic case reporting measure for 2025, it did receive support. Commenters pointed out that the CDC had paused onboarding new participants, which made it impossible for many clinicians to beat the measure, creating a penalty scenario that was completely outside of their control. This situation was frequently cited as an example of why CMS needed a broader suppression policy. So CMS's goal with this suppression was basically to ensure fairness. They agreed with commenters that it was inappropriate to penalize clinicians for their inability to connect with a partner like the CDC. That was not ready for them. So this action prevents widespread unfair penalties for the 2025 performance year, and it serves as an immediate justification for adopting the new general suppression policy for 2026. And you all have experienced measures being suppressed before. You just haven't seen it in the PI category. You've seen it for quality measures, right? At the end of the year where they'll truncate and suppress and they'll send out a notification. This is similar. They didn't have this for PI before, so now they do. However, I do want you to note that even though they're going to end up suppressing the measure for 2025, you do still need to attest to it, like mechanically in whatever system you're using. If it's P360, you're going to select either the exclusion, which is the PI 3X3, any MIPS eligible clinician who operates in a jurisdiction where no public health agency has declared readiness to receive the electronic case reporting, or you can do the pre-prod one, which is the PHC DRR3 pre. The MIPS eligible clinician is in the process of moving towards sending production data. So you'll still attest to it. They're going to end up suppressing it anyway. For 2026, the new attestation for the security risk analysis SRA measure was generally supported by commenters. Stakeholders understood the intent, which is to move the SRA from a simple check the box attestation to a more meaningful safety process. Next slide, please. All right, MVPs. MVPs have been running concurrently with MIPS now for several performance periods. We haven't seen a massive adoption. We're seeing bits here and bits there. And at this point, there's really a decent inventory. So if you have an MVP now that's representing your specialty type, there's really no reason not to submit the MVP. CMS's goal is to phase out traditional MIPS and fully replace it with MVPs, possibly by 2029. So it's coming. We're in a crucial transition period right now. So really use this time to ramp up and use the MVP with low or no added risk, right? Consider reporting both and CMS will actually take the better of the 2 scores. It's really a win-win. There's no reason not to. You're also in the MVP, you only have to report 4 quality measures as opposed to MIPS where you're reporting 6. So that's kind of a nice win, a reduction in the amount of quality measures that you have to report. So definitely give that some second thought, the MVPs, because it's a win-win situation. Next slide, please. Oh, new MVPs. Yep. So just wanted to list them right here for you quick so you can see them and you can refer to this. But these are the ones that were finalized. So they're really trying to expand those specialty types so that every specialty type will be represented by the time they fully sunset MIPS. Next slide, finalized changes. There were all 21 existing MVPs were finalized with modifications. So the most important thing to know is why they were changed. And this is to align with the newly finalized MIPS measure inventory. So because CMS finalized the removal of 10 quality measures, 8 improvement activities from the MIPS programs, they did have to update the 21 MVPs to remove those same now retired measures and activities. So program alignment. The most important items to note about the MVP changes. So inventory synchronization was the main driver. Every MVP that contained one of the 10 removed quality measures like the 487, the SDOH screening, or the 8 removed improvement activities, that was updated for alignment. This is a strategic policy shift. Again, the most significant theme in all of these, as we keep seeing over and over again, is the removal of specific health equity focus to a health and wellness focus. And then, of course, moving away from process over to outcomes-based measures. Next slide, please. Okay. MVP's finalized changes. So here's a bit more on the finalized MVP registration policy. So there's a mandatory subgroup reporting for large multi-specialty groups. So what it means is if a practice has more than 15 clinicians and it's multi-specialty, it can't register anymore for an MVP as a single larger group. You're now going to be required to form and register as one or more of subgroups for MVP reporting. It's important because it's a critical operational deadline. So if you're a large, diverse organization, you can't report as a single entity anymore if you're doing the MVP. You instead have to identify your distinct specialty-specific cohort, like a cardiology subgroup or a primary care subgroup, and manage multiple separate MVP reporting. So how do you identify your subgroups? They're actually going to have a new finalized self-attestation during the MVP registration process, so you don't have to rely on the old, flawed claims-based method, which misclassified half the time anyway. So at least it's a self-attestation. Wanted everybody to know that that got finalized. Small practices there's still the exemption for them though. So if you're a small practice with fewer than 15, you can remain in a single group and you don't have to worry about the subgroup reporting. Next slide, please. So to make the MVPs easier to navigate, this is just something that I wanted you to see for finalized changes. They did finalize the new clinical groupings format. We showed this during the proposed rule. Basically, you can see here on the bottom the experience of care and the way they've regrouped. Clinical groupings, it's a new table format for the 21 existing MVPs and the 6 new ones. It organizes the list of available quality measures into logical categories. And this is important because instead of just showing one long list of measures, it formats groups by clinical condition or by cross-cutting theme. It's similar to what they've tried to do over time, you know, with different quality measures. They have specialty groups and, right, they're trying to group and make the clusters more logical. Okay, next slide, action item. So there is still time for MVPs to register here in 2025 to report by MVP. And again, like I mentioned, there's really no reason not to, because if you dually submit for both programs, CMS is going to take the better of the 2 scores. So if you haven't considered an MVP yet, we highly recommend trying it. Okay, taking a breath, sip of water. We're going to move on to the ambulatory specialty model. Garrett, everything's still loud and clear.
We're still good.
Okie doke. Okay, so ASM model. The CMS Innovation Center has indeed finalized its new 5-year mandatory ambulatory specialty model. It's indeed confirmed to begin for 2027. We'll talk more about this. As finalized, it's a mandatory program. It's not optional. That was finalized. The new model is going to assess performance based on the measures and activities in the ASM quality, cost, improvement activities, and promoting interoperability categories. As finalized, the model is going to place the primary weight focusing on quality and cost, so 50% each for those, which is a significant departure from MIPS. So what's the intention of the new model? The rule confirms that the model is designed to help patients stay in good health and keep costs low by promoting prevention, upstream management, timely targeted care for 2 specific conditions, heart failure and low back pain. The key here is prevention. So CMS is targeting these big ticket conditions known for their massive annual costs. The program is designed to drive patient-centered outcomes, focused care, while in CMS's words, reducing spending that represents low value services and major cost drivers. Next slide, please. So how did CMS finalize ASM eligibility? So eligibility for this new model has been finalized to be evaluated at the individual clinician level only. So here's how CMS is going to determine if you're eligible and required to report for the ASM model. So specialty type. First, you're going to have one of the defined specialty types listed on your Medicare Part B claims. For the heart failure cohort, CMS is looking at cardiologists only. For the low back pain cohort, CMS is looking for anesthesiology, interventional pain management, neurosurgery, orthopedic surgery, pain management, or physical medicine and rehab. What about case minimum? So clinicians must bill Medicare Part B claims and meet a case minimum of 20. We're used to hearing that, 20 attributed case episodes from MIPS. So everybody's kind of used to what's the minimum in order to get credit? It's 20 patients. The eligibility is finalized to be determined using a 1-year look back period. So for example, a cardiologist who has at least 20 heart failure cost measure episodes in 2025 will be finalized as a mandatory participant for 2027. CMS also finalized that ASM participants must be located in one of the selected mandatory geographic regions. CMS will use a stratified random sampling method to select these regions, accounting for factors like population density and high-low spending. They also finalized that ASM participants will be exempt from MIPS reporting for each performance year that they're required to report in an ASM. So that was finalized as well. Okay, so how and when will we find out if we are eligible is the big question. The final rule, section 3C, does outline a multi-pronged notification strategy. There's going to be the following to let you know that you are eligible. Direct notifications via letters and emails from CMS to the contact information on file in PACOs. So please make sure PACOs is updated on a regular basis. That's just important to do anyway. Via public posting, CMS is going to publicly post a list of selected geographic regions and the full list of individual clinicians selected for participation on the official ASM site. When are you going to find out if you're required to report the ASM? So the preliminary list is going to be released in early 2026. That's coming up around January or February or so based on 2024 claims data. And then the final list is going to be released by July of 2026 based on 2025 claims data. And here's what CMS directly states. We are finalizing our proposal to produce a preliminary list of ASM participants using 2024 data for the 2027 ASM performance year, 2029 ASM payment year. So payment adjustments, it's still that 2-year lag. We'll cover that in a minute. Using applicable data from the 2025 calendar year as proposed. We are also finalizing as proposed to reassess clinicians for ASM participation annually rather than use a fixed list of ASM participants for all ASM performance years. Next slide, please. So data submission requirements. Aside from eligibility, there were some helpful modifications based on commenter feedback made to the data submission requirement for small practices specifically. So we did get a couple of modifications. It's a miracle. We're modifying our proposal to allow ASM participants in small practices to report the quality measures in the ASM performance category at the TIN level. After consideration of commenters' feedback, we are finalizing 512.720 that ASM participants who are part of a small practice may submit quality ASM performance category data at the TIN level. We believe this would reduce burden for small practices. We will monitor the performance of these small practices to determine whether there is a future state in which we could reconsider mandatory TIN NPI level reporting of quality measures for small practices. So it's a small win, but we're going to take it. And we know that detailed information about the process by which small practices will report as a TIN for the quality category will be released in the participant information section of the link on this slide here. So you want to keep monitoring the link in the slide in the coming months, as that's where CMS is going to release more details on the mechanics of how to report ASM quality measures at the TIN level for small practices, because they didn't really go into, they changed the policy and modified it, but as usual, they didn't bake out the technical aspects of, well, if everybody else is reporting as an individual and they're from a large practice, how are small practices reporting as groups, right? There's some technical things that need to be worked out there. So I think we're going to find more information about that in the upcoming months on the link in this slide. Next slide, please. Okay, so let's look at the measures, right, for each of these cohorts. So everybody commented that measure 377 was burdensome and had many other issues and comments about this measure for CMS, but they still finalized it. So they did mention they would consider a respecification of the measure into a pro PM through future notice and comment rulemaking, but they did finalize it for 2027. So the finalized list is here of the measures that you'll need to report. For the cost measure in this ASM, which is 50% of the score, CMS did finalize the heart failure, episode-based cost measure, the EBCM. Commenters generally agreed that it was the most appropriate cost measure for this cohort, and it's already used in the MIPS program, so it's clinically relevant to the specialists being included. It quantifies, it quotes, quantifies the cost of services that are related to how the provider clinically manages a patient with heart failure and aligns with the advancing care for heart disease MVP. Next slide, please. Okay, the low back pain measure set. So similar to heart failure, everyone was critical of measure 220, but they did still finalize it. They said, we recognize the potential effort that further implementing this measure, meaning measure 220, may introduce, but it is vital to the integrity of the model as it represents our best outcome measure available for low back pain. These measurement activities should be occurring to ensure improvement in patient outcomes, and therefore we will include the measure in our set. We hope that in future rulemaking, they will include other measures, and we'll be staying tuned for that instead of 220. For the MRI lumbar spine for low back pain measure that was proposed, they're not finalizing it. They're going to revisit that in the future rulemaking, and they've left it, you can see on the 5th line there, to be determined. Okay, next slide. IA improvement activities and promoting interoperability. Okay, so those were finalized as proposed. The win for these two categories is that everyone can report those at the TIN level. So yay, at least two categories that you can do at the group level. The improvement activities category under the ASM is intended to incentivize practice improvement that would strengthen care management related to targeted chronic conditions and encourage stronger relationships between specialists and primary care providers. Similar to MIPS, IAs are going to have a 90-day reporting period, and ASM participants are expected to attest yes to the completion of IA1 and IA2. CMS finalized that ASM participants who complete both IAs would not have a negative scoring adjustment added to their final score. Participants who complete one IA will have -10 points applied to their final score, and participants who do not complete the IAs will have a -20 points applied, right? So for not doing it, you're going to get negative. For doing it, you don't get anything. So it's not like MIPS where if you do the IAs, you receive 15 points. Instead, if you do them, you get nothing. And if you don't do them, you receive a reduction from your total score. We're going to show you a breakdown of the category weights and scoring adjustments on the next slide. For promoting interoperability, same concept. So under ASM, it's intended to assess participants in their efforts to promote patient engagement and electronic exchange of information using CERT, much the same as MIPS. It's similar to MIPS and MVPs in its intention as well. CMS finalized the minimum of the 180-day reporting period, same as MIPS. However, just like what I mentioned with the IAs, again, if you do the PI category, you don't receive points. If you don't do the category, you receive a reduction of points. And there will be no PI hardships available and no exceptions, even if you are from a small practice. We're going to show you a breakdown of the scoring methodology on the next slide. So let's go there now. Okay. So in order to calculate a score from 0 to 100, CMS has assigned an ASM performance category weight of 50% for both quality and cost. The improvement activities and promoting interoperability categories are not weighted. Instead, they function as pass-fail requirements. So ASM participants who fail to meet the reporting requirements for these categories will receive a negative scoring adjustment subtracted from their total score. Why are quality and cost worth so much? So these weights align with the ASM goal of decreasing the cost of care for beneficiaries with targeted chronic conditions and increasing the quality of care. They're also hoping that this is going to broaden the distribution of final scores. CMS is not going to make the small practice PI exception that we see for traditional MIPS and MVPs available under the ASM. However, okay, instead what they're going to do is 10 points are going to be added to the final ASM score for small practices with 15 or fewer clinicians. And if you're a solo practitioner, you'll get 15 points added to your final ASM score. So it's basically going to be a wash if you don't or you can't do the promoting interoperability category. So the PI will show up as you're getting the negative for not doing it, but then at the end they'll tack on the additional points if you're from a small practice or you're a solo clinician. Bottom line is CMS is really pushing use of CERT, although they do acknowledge that they have received feedback from small practices and solo practitioners that face challenges in their inability to participate in MIPS due to costs to implement and maintain CERT, staff and training costs, limited staff capacity to manage the complexity of the program. They acknowledge, so that's likely why they provided the bonus point avenue for the small practices and solo clinicians. Next slide, please. Okay, more on final scores. So in order to earn a final score out of 100, CMS finalized that an ASM participant must meet the data submission requirements for the quality performance category and must receive a performance score for at least one of the two categories, quality or cost, to be eligible for a payment adjustment. The table on this slide is showing you different scenarios, okay, of final scores and corresponding payment adjustments. So for example, if you earn a score for both quality and cost and therefore earn a final ASM score, the ASM participant will be eligible for a positive, neutral, or negative payment adjustment. To get a calculated final score from 0 to 100, you've got to get a score in at least one category, quality or cost. If you submit your quality data but still end up with no score for quality and no score for cost, you will be held harmless and receive a neutral payment adjustment. Well, how does that actually happen though, right? So it would be possible that you don't receive a score for quality if the measures either don't have benchmarks or if they don't meet the required case minimum of 20. So if you don't have enough patients. Remember, we talked about that case minimum before. Similarly, it's possible to not receive a score for the cost category if you don't meet the 20 case minimum, patient case minimum for that one as well. So to recap, once you successfully meet the 75% quality data completeness requirements for at least one non-claims measure in the model, CMS is going to calculate a score for quality. You want to try and submit good performance data for all the quality measures in the model because if you don't, your quality score will be negatively impacted, similar to MIPS or MVPs. If you get a score for both quality and cost, your final score is weighted at 50-50. If you get a score for quality only, but no cost, for example, by missing the 20 episode case minimum for cost, your final ASM score will be based 100% on your quality score. So you'll then be eligible for a positive, neutral, or negative adjustment. The only way to get a neutral adjustment is if you meet the quality submission requirement, but you're unscorable in both the quality and cost categories. So the next slide, we're going to review how these scores actually impact the payment adjustments. Next slide. Okay, so risk level. CMS defined the risk level as the magnitude of the maximum positive or negative payment adjustment percentage that can be applied to an ASM during the applicable payment year. So as you can see in the table, payment years were finalized to occur 2 years after the performance year. This aligns with MIPS. We are all familiar with this. CMS finalized to start with 9% for the first 2 payment years, given its continued use within MIPS. So again, we're used to that 9%. This means that for the first 2 ASM performance years, the maximum negative or positive payment adjustment could reach up to 9%. So CMS believes in increasing the risk level over time, as this is going to provide an incentive for increased accountability. Beginning with the 2029 payment year, CMS finalized the redistribution percentage to be 85%, which means that 85%, and this has been finalized, we already saw it in the proposed rule, they definitely finalized it. It's going to be 85% of the ASM incentive pool, and it's indeed to be redistributed to the ASM participants. And then 15% is going to be retained in the Medicare Trust Fund. This is exactly what they proposed. CMS believes that this 15% to the Medicare Trust Fund ensures a particular level of net savings that would contribute to the net savings in the total cost of care, and they did discuss and finalize this. So let's look at the ASM incentive pool on the next slide. Okay, so this is a little bit different than budget neutrality, so we're going to go through this now. An ASM incentive pool is a fixed percentage of the total amount of Medicare Part B covered professional service claims paid to ASM participants, with final scores that will be distributed in the form of scaled payment adjustments during an ASM payment year. CMS will calculate the ASM pool using the ASM risk level for the appropriate payment year and the ASM redistribution percentage. So here's an example directly referenced. This is from the final rule. We know that the first 2 payment years will have a risk level of 9%. We know that CMS is finalized to set the redistribution at 85%. And so let's assume that the sum of the ASM participant Medicare Part B payments totals $1 billion. Multiplying these values together will get us to a $76.5 million ASM incentive pool. To complete the scoring and payment adjustment calculation, CMS is first going to calculate the incentive pool. Then they're going to calculate the adjustment factor, which is a percentage value calculated using your final score. Isn't this what fun this is? The appropriate risk level percentage and CMS scaling factor. And they're also going to calculate the payment multiplier and the overall payment adjustment. So it's important to note that CMS is planning to calculate separate ASM incentive pools for each cohort, right? So low back pain and heart failure, it's 2 separate cohorts and incentive pools. So the main takeaways here. The way you get paid in the ASM model is different from what you're used to in MIPS. In MIPS, your bonus is often small because it depends on taking money from the few doctors who actually get penalized. The ASM model is changing this. It's creating a guaranteed incentive pool for each specialty group. CMS calculates this pool based on the total revenue of everyone in your cohort, so all heart failure specialists, creating a defined pot of money available for performance bonuses. This means that your potential upside is determined by the size of your cohort's pool, not just by how many people fail. You will see exactly how this affects your payments in your ASM performance report. Next slide, please. Okay, so action items for ASM. What can we do now to prepare? Because they did finalize it. It's coming down the line. We did ask for a delay, but no delays. No delays will be had. So you want to be on the lookout for your eligibility. Preliminary lists will be released in early 2026 based on 2024 claims data. The final list is going to be released by July of 2026 based on 2025 claims data. You want to review the measures in the model. So we have them all in this slideshow, so you don't have to dig through statute. It's back a few pages, but you can refer to these anytime. You definitely want to make sure the measures are programmed in your EHR. And I would note that both sets, okay, have at least one ECQM collection type measure only. I think low back pain, it's 128, ECQM only collection type. And then the heart failure cohort that also has an ECQM measure only. Pay attention to that, because if you're not on a certified electronic technology, that will impact you and your score for that particular measure. You want to make sure that you know how to document for these and start in 2026, so that when 2027 rolls around, you're going to be well prepared and ready to push data over early and often to patient 360. If you're not on a 2015 cert product, we highly recommend exploring this option, as it's required for this program and many other programs within the quality payment program, especially since we know CMS is moving towards the DQM adoption, which is going to require cert technology. Next slide, please. Let's get a poll from Garrett.
All right, and we'll give Amanda a second to catch her breath and get a glass of water here. Second polling question is this, and you will see it up on your screen here. If you commented on the 2026 proposed rule, how many of your comments were directly addressed by CMS? Was it all of them? Maybe one or two? None of them? Or I did not comment? So we're going to take just a second here to let these results come in, and then we will read these out for you so you can see. And if you're joining us late, these are anonymous. We're having a couple polls here, and so feel free to participate, and we will show the results here. And I'll close it down about another 5 long seconds, and then I will read out the results to you. All right, I think most people have voted, so 5, 4, 3, 2, and 1. Okay, Amanda, so it looks like 84% of those with us today did not comment on it. And then we got 14% that said 1 or 2. And then 2% said none of them.
Okay.
And 0% said all of them.
Fair enough. Okay. Well, that's okay, because we commented for you. 42 pages of comments. Only a couple modifications. They were all acknowledged, though. So recap of our public comments. On this slide, we did weigh in heavily during the comment period. 42 pages, I remember. In fact, they acknowledged all of our feedback in the final rule. They did acknowledge it. We didn't win every battle this round. Maybe one of them where they're modified, and not every suggestion became a rule change immediately, but the fact that they're engaging with our specific points, it is a solid step in the right direction for future rulemaking. So sometimes if they'll say something is out of scope, or we acknowledge, we thank you for your comments, and they actually have our comments in there, which they did. I could see word for word some of the things that I mentioned and that we mentioned in our comments. That's a good thing, because even though it wasn't acknowledging that they're going to make any changes in this final rule, they could use those comments for the next proposed rule session, which would be great. Here's a few examples of the items that were actually acknowledged. So a win, the MVP subgroup reporting flexibility. CMS finalized a policy allowing multi-specialty and small practices of 15 or fewer to continue reporting MVPs at the group level, so they're not required to form subgroups for MVP reporting in 2026. This does reduce the administrative burden for smaller specialty groups. So that was a win. Another win is that ASM participants that are part of a small practice, they're going to also be able to report at the TIN level. So that was a win. It was definitely a modification, because initially it was just everyone will report at the individual level. And for small practices, that's really hard. A loss. So we really did try to request to extend the MSSP ACO EUC for specialties within an ACO that are not able to obtain data, or that are on EHRs that are not certified. That was rejected due to being out of scope. ACO composition is voluntary, and therefore the responsibility of the ACO to strategically and intentionally select their TIN composition. So we really did try, but we're glad that our comments were at the very least acknowledged. Next slide, please. Just to make this easy for you, we do have links here that will take you to the actual published final rule, the QPP fact sheet, so you don't have to rummage around. You can use this slideshow. There's page numbers on everything. We want you to have everything at your fingertips so that you don't have to go in and read. Because it's a long document. Okay, some final action items. So as we wrap up today, I want to emphasize with everyone joining that it's really important that you're actively engaged. This is a big thing. Log into your QPP portal if you haven't recently. You want to do that on a regular cadence. And if you don't know what I'm talking about, go to the QPP website and get yourself registered for the QPP portal, and you want to be a security official. we're not security official for many of your organizations, so we don't have access to the same information as you. And there's a lot of information related to your eligibility, your scores, your payment adjustments in QPP portal, as well as the ability to register for the MVPs that I was telling you about are so important. May as well. Registration is still open for those for here in 2025. Also, you apply for your hardships there as well. So your promoting interoperability hardships and or your EUC, that all happens via QPP. So you want to log in there early, often, and regularly. For ASM preparation, you want to check in on the innovation page and the link on the slide that we provided for your eligibility in January. And let's see, do we have a minute and 2 minutes left, Garrett, for any questions?
Let's see here. We do have, we are kind of right on the top of the hour.
We are, and I have those final recommended items. Okay, are you collecting everything? Ahead. Okay, you're collecting all the questions, right?
Yeah, let me make a note about this. If you do have a question, and we do have some that have come in, don't worry. Someone will reach out to you to make sure we get your question answered. So go ahead and ask them, but we'll have to reach out to those and answer them via email. So if you want to hit on your final notes, Amanda, then we'll close it up.
Well, I just really wanted to thank everyone for attending today. I know that it's a lot, it's high volume to cover. So we have recorded it. We will get everything sent out to you. And many of you, we talk on a regular basis. So if you have any questions that I couldn't address and we're working on implementation calls together or whatnot, please feel free to reach out to me directly. And then our action items on the final slide, it's just really important for you to continue to log into QPP as early and often as possible, just so that you can see where you stand, ensure that you're looking at your scores from last year and plan the best for the future. So we really thank everyone for attending, and for sure, we'll make sure that all of your questions get addressed.
Great. And actually, I do want to read one comment that came in. It says, Amanda and her team at P360 do a fantastic job with our data in helping us to understand our data and the rules. Highly, highly recommend. So I will pass along at least that comment in the time that we have. And I would attest to that as well. As we close out here, first of all, Amanda, thank you for a fantastic, very thorough presentation. I'm sure you'll be hyperventilating here for a little while as you're recovering from the presentation. But as we close out, I want to encourage you to head over to vbcexhibithall.com and check out the virtual exhibit booth that Patient 360 has there. There's an image on the screen here. There'll be a link to it in the slides for you to download, and we'll be sending out a link here shortly to the recording and the slides, which I know you're going to want to review because there's a lot of information on there. But here's where you can kind of read up on them, see what they're doing in the space. There's some resources there available for you, and of course, you can reach out to their team there. And then in that final slide again, if you want to reach out directly to the Patient 360 team, their information is there, or I'm happy to connect you as well. So you can reach out to me, and I'm happy to facilitate an introduction. But I want to thank you all so much for joining us today, and hope that you will come to see us on the next one. So until then, have a very great rest of your day, and a happy Thanksgiving next week.
Thanks, Garrett. Happy Thanksgiving.